Can you see my slides okay?
Yeah, we can.
Okay, great. So Botswana has a small population and has been very progressive since independence in terms of building free healthcare and education. It still has high unemployment and high income inequality, and obviously has suffered from a high burden of HIV. It started the first national free ART program on the continent as far as I'm aware, in 2002. And really had a CD4 treatment initiation criterion of less than or equal to 350 until 2016, when it went to treat all. So the primary aims of the Ya Tsie study, or the Botswana Combination Prevention Project study, which was performed in Botswana, were to determine whether a package of interventions, primarily universal test and treat, and really, if I should underline test everywhere, because that's really the cornerstone, significantly reduces population level cumulative HIV incidence, to understand what the population level uptake would be of the intervention components, to evaluate the cost effectiveness of the intervention, and to explore viral transmission patterns through viral phylogenetic analyses. The study was conducted in 30 rural and peri-urban communities, each with an average population of about 6,000. So the total population of involved in the study was about nearly 200,000, or nearly 10% of the entire population of the country. And age eligible individuals, 16 to 64 years, comprised about 105,000 people. And you can see the community pairs, 15 community pairs were kind of scattered throughout the area of the country where people reside. Over towards the left in the middle is the Kalahari Desert. So the interventions in we call them the combination prevention communities, the intervention communities, consistent of community engagement and mobilization, universal HIV testing with an aim to test all residents aged 16 to 64 years who were not already documented to be living with HIV, active linkage to care support, and then universal ART as of June 16, which is when 2016, which is when the country also moved towards treat all. Before then, expanded treatment for residents with higher viral load, over 10,000, if they did not meet the local CD4 or AIDS illness criteria. So we were a little different than some of the other test and treat studies, and enhanced male circumcision services, which I'm not going to get into in too much detail. In the standard of care communities, individuals receive standard of care, ART for if CD4 or less than or equal to 350, WHO stage 3 or 4 disease, or pregnant or lactating, until June 2016, when, as I mentioned, all communities moved to treat all, universal ART. So you're familiar with the three other large universal test and treat trials. This just shows for Ya Tsie, Pop Art, Search, and TASP, the kind of the crux of the interventions in the intervention communities, and then what happened in the control communities. So just wanted to point out that Search, I think, as you know, did baseline home-based HIV testing in their control communities as well as the intervention communities. And that also happened in TASP. Ya Tsie and Pop Art did not do the universal testing at home. So I think that is an important distinction. All of the studies, except for TASP, so including Botswana, the treatment, ART, was delivered in government public facilities by government staff, which is important. We helped augment the staff in numbers a little bit, but the intervention was not, the treatment intervention was not delivered through the study. Our main study endpoints were HIV incidence, which was measured via longitudinal follow-up of a community-based HIV incidence cohort. And this incidence cohort was enrolled from a random approximately 20% sample of community households from each of the 30 communities. And the primary study endpoint was cumulative HIV incidence over approximately 30 months. Originally, we'd hoped for 36 months, but it ended up being 29 months for a number of reasons. And then we also had pre-specified assessment of coverage parameters as another primary endpoint. So intervention uptake, which we measured both through annual household surveys and an end of study survey, as well as program monitoring data in both people with and without HIV. And then the viral phylogenetics, which I will not speak to, and Larato will cover more. So this is just a schematic of the study design: 15 control or standard of care communities, 15 intervention or combination prevention communities, a random sample of 20% of households in each of the 30 communities was approached, and all eligible adults who consented were enrolled, both persons with and without HIV, and followed longitudinally. And then in 3 pairs, 6 communities, we did a full re-enumeration and reassessment and enrollment of all eligible adults in those 3 pairs or 6 communities at the very end of the study to understand uptake and also get additional samples. So we obviously started with and continued throughout community engagement, which I think I don't need to belabor is obviously key to any kind of intervention of this nature. It was essential and incredibly important. We also, in all 30 communities, mapped every single household in each of the 30 communities with GPS coordinates and a unique plot ID assigned. And we ultimately mapped about 74,000 plots in total. Obviously, household and individual data were linked to each plot, and a random sample of 20% of plots or households was selected for the household survey and the incidence cohort, and then followed longitudinally. These maps in the intervention communities were also used by the HIV testing campaigns, which in the initial round were home-based testing to try to reach everybody in the community. And this was a way of tracking where people had been and where they needed to go back to. And we collected data on tablets electronically. So what did we find from our baseline pre-intervention household survey now in all 30 communities? So you're familiar with the 90-90-90 targets. At baseline in Botswana, 83% of the persons whom we found in households, and this I should have said, I apologize. Our baseline survey enrolled 12,610 participants in this 20% cohort. This was, our goal to have a representative sample of all 30 communities. And in this group, 29% of persons were found to be living with HIV, and 8,974 HIV negative. So at baseline, 83% of the 3596 persons with HIV already knew their positive status. 87% of those who knew their status was on ART, which is remarkable considering that the treatment threshold was less than or equal to 350. And 96% of persons on ART had a viral load of less than 400. And this is also quite impressive, given that this is kind of a cross section of everybody who was on treatment. So this is not people who are showing up in clinics. This is in the households. So overall, 70% of all persons with HIV were virally suppressed at baseline, and this compares to the 73% overall 90-90-90 target. So if we compare this to the other studies, our prevalence was high, similar to that seen in TASP, higher than that in POPARD, and certainly much higher than that seen in Uganda and even in Kenya in the SEARCH study. Our baseline ART coverage, again, in all persons living with HIV, including those who did not already know their status, was 70%, as I mentioned, so higher than that in the other studies. So we clearly, with our intervention, did not have as much improvement to make in Botswana as in many places in the world, certainly including the United States. But despite this very high baseline ART coverage, this plot shows in blue in women and in red for men by age, the HIV viremia prevalence in the overall communities. So you can still see that despite the very high coverage, men in the early 40s and women in the early 30s, there was reasonably high prevalence of viremia in the general population, in the sexually active population. So ongoing incidence and transmission, of course. So what did we find in terms of actual implementation of the interventions? How well did it work? And I should have noted that many of these slides are borrowed from many colleagues, both from Botswana, Harvard School of Public Health, and from the CDC. And these next slides are from our CDC colleagues who were collaborators in this project, along with the MOH and Botswana Harvard Partnership and the School of Public Health. So the HIV testing intervention was really comprised of a one-time intensive campaign initially, with about 2 months spent by the testing groups in each community to test all adult residents, home-based testing followed by mobile testing. That was simultaneous mobile testing in areas with high traffic and with testing in nights, weekends, holidays, and multiple visits to reach all eligible. Following this initial intensive round, which was obviously resource intensive, the testing strategy was adapted to focus on trying to test people who were missing or underrepresented in the first round, where we could find them. And this was primarily men and youth, so workplaces, markets, bars, cattle posts, etc. And additional targeted testing at community events and multi-disease health fairs. So just bringing out a couple of points on the testing. Although this shows by females in green and males in yellow, and by age bin towards the right, the numbers tested, and then the quote unquote yield. So the percent of those tested who were newly diagnosed to be positive. So this excludes people who were already documented to be positive. And so in total, about 22,600 persons were tested in the home in the intervention arm, and versus 26,000, slightly more in the mobile venues, but slightly more newly positive persons were diagnosed in the home, 1,100 versus the community tents, 900. And interestingly, men, especially older men, well, younger as well, but men, as noted, can be harder to reach. And in men who are found in the homes, in age 35 to 64, 9% of those tested were found to be positive. So home-based testing had an important role in this, which I just wanted to stress, although it is more expensive. This shows from study start in blue to study end in orange, the increases in population level knowledge of one's positive HIV status from study start to study end, women on the 3 left-hand sets of bars, men on the right. And you can see that women ended up with higher first 90s knowledge of positive status than men, but the incremental gains were actually even greater in men, particularly in young men. So this was important success in that population. I've said much of this. I just wanted to note here that over 40% of the persons who were referred to start ART actually already knew their positive ART status, were not yet on ART. So another important role of the testing campaigns was to kind of engage with those individuals and refer them. And we concluded that even when testing coverage is already high, additional gains can be made using this multimodality accessible HIV testing strategy, including in important subpopulations who are usually missed. So what about linkage? So initially, all persons who were positive and referred to clinics to start treatment were given appointments at the local HIV clinics, which is not traditionally done. And everybody received an automated SMS appointment reminder, which is also atypical. Then people who did not attend that clinic appointment were traced by community linkage to care managers with telephone calls, and then, if permission was given, home visits. And this was facilitated by existence of a national unique identifier or passport number called the OMUNG. Those who weren't linked within 90 days were sought then in the National Electronic Database, and to see if they linked to a different community. So ultimately, overall, 93% of persons who were referred through this intervention, this is now CDC data, a slightly different source of data, actually linked to care. Slightly more women, over 25, 95%, but even men, older men and youth linked at about rates of 90%, which was really good. 49% of those referred kept their first appointment at the community clinic with no additional intervention. So that was great. An additional 27% linked to the local community clinic after being traced by the linkage to care manager. So that was a relatively simple, low cost, but really important piece of the intervention. About almost a third of people linked with that intervention. And then we found that 17% of people who linked did so outside of their community of residents. And we anticipated this would be the case because of concerns regarding stigma in these small communities. Only 7% never linked. Nearly 90% of those who did link did so within 3 months, which was a little faster than I think was observed in some of the other studies. We also in 2016 moved to a fast track ART initiation where adherence counseling, contrary to multiple rounds of adherence counseling and several pre-ART visits at the clinics per the usual standard of care, adherence counseling was already started among persons found to be positive in the community. And then ART was started at the first clinic for people who were stable and willing, and labs were drawn but were not waited for. And so this shows in red the time from linkage to clinic to ART start in the rapid ART arm compared to blue, the pre-rapid ART or usual standard of care arm. And basically you can see that there was much more rapid ART start as you would expect in this rapid ART era. And very importantly, the rates of being engaged in care and virally suppressed among those who started ART were essentially identical and very high in both of these eras, 91 and 92%. This shows the overall care cascade according to the population data. I'm going to show two general uptake slides. This is using the kind of the implementation programmatic data, and then I'll show our cohort data. They're actually quite similar. So this, at the end of the study, 93% of persons who were estimated to be positive in the community knew their HIV status. 93% of those were individuals who were on ART, and 98% of those were virally suppressed. It was 95% were virally suppressed among those who were missing a viral load. So overall, 85% of those believed to be living with HIV in the community had viral suppression by the study end. This shows the same cascade, but from our 20% cohort and our end of study survey populations. And essentially, without belaboring the details, we went from about 70% of all persons with HIV having an undetectable virus before the study to 88%. So this is comparable to the 86% from the programmatic data. So about an 18% jump, and this number basically is around where you need to be to reach the overall 95 target of 86%. So I won't reread this. This more or less reiterates some of the findings, and I'm sensitive of time. So incidence. We measured HIV incidence in this 20% cohort. Again, about 9,000 HIV negative individuals were enrolled from this random sample of 20% of each community. The median duration of follow-up was 29 months, and 95 to 96% of participants in each arm retested for HIV during at least one follow-up visit, so retention was good. And in the primary unadjusted analysis, the annual HIV incidence was 0.59% in the intervention arm versus 0.92% in the standard of care arm for an unadjusted incidence ratio of 0.69. And the adjusted incidence ratio was 0.63. So for the initial permutation test, p-value was 0.09, and you can see the confidence intervals 0.46 to 0.9 for the unadjusted. So in totality, we felt that our results indicated a 30% or greater reduction in HIV incidence associated with the intervention. And as Lorato may talk about, and one of our main points that we're really interested in still exploring further with the viral phylogenetics data is that our impact of the intervention was likely substantially blunted by mixing or infection acquired from outside of intervention communities. This shows the curve of population HIV incidence in the intervention in blue and standard of care arms over time on the left, and then the map of HIV incidence over the entire period by community and randomization arm. Red is standard of care, blue is intervention. You can see quite a bit of variability by community and region as well in both arms, but just wanted to note that we saw a greater apparent impact of the intervention on HIV incidence in men. You can see highlighted there in red below the incidence ratio of 0.4 on the right compared to 0.7 in women. And by age, again, impact seems greatest in the 25 to 34-year-old age range, and by region, actually statistically significant in the northern region alone, where incidence was also higher, but the impact was also higher. So very quick lightning rounds. Mortality still was higher in persons with viral suppression on treatment for more than 10 years, still threefold higher than persons without HIV, but the cause of death in persons with HIV overall started to more closely mirror that in persons without HIV, with cancer and renal, other non-infectious medical diseases and trauma still pretty highly represented in both. More mobile persons with HIV were more likely to be viremic, both because they were less likely to know their status or less likely to be on ART compared with non-mobile persons. So this was important, also will be relevant for the phylogenetic analysis. Despite efforts targeted at reducing multiple concurrent partnerships, about 1/3 of sexually active individuals still reported multiple MCPs. We found a high prevalence of hypertension in both persons with and without HIV, and about half of them were untreated. We did a sub-study on that. And Vlad and Sikulili led this among many other studies, but we found this has been seen elsewhere, but about 40% of persons with viral load less than 400 who reported not being on ART had ARV traces found in a blood sample. So I think I will stop there to leave enough time for Lerato. I do have some slides put together by our cross-UTT trial consortium comparing and contrasting several of the findings from the different trials, but I think in the interest of time, let me stop there.